This is great to be up here, and I speak all over the country, and I've been doing this. I know I only look 16, so don't say anything about this, but I've been doing this actually since about 94, 95. I was in clinical practice, as he was saying, up in Evergreen, where we did all the emergencies, all the clinical medicine, the family medicine up there, and it was clear to me then that this system is just not sustainable. I mean, from a practice point of view, from a patient's point of view, from a payer's point of view, employer point of view, as Marion was saying, there's really no system. It was like as if you developed you built a city, you had no architectural plan, so you've got a gas station kind of sitting right in the middle of a grocery store that's sitting right in the middle of a farm. So, I want to talk to you a little bit about, what my job tonight was really to kind of give a very high level of what's happening in the healthcare arena. And obviously you all, many of you are critical access hospitals. You're coming from a very different perspective than some of the big hospitals that are in the cities. Some of them are forming mega systems, buying each other, consolidation. So you're going to have some different issues. And so I'm going to kind of give you a picture of what's happening out there around you. And then I'd like to, we can definitely focus back down on, and I know tomorrow we're going to spend a lot more time with Janet talking about what are some of your specific issues, but we can certainly start to talk about that a little bit tonight. So it's very interesting that people will pay $100 for a massage without a thought, right? But do not make me pay $10 for my copay, right? Right? I was like, wow, I'm not gonna pay that. So that is a value proposition, right? We have lost value in what we deliver. And so we have to start thinking differently. And by the way, I think we've all realized it in healthcare. We are not happy, right? We gotta do this differently. And we realize we can't do it alone anymore. It's just too complex. It's just can't be that I'm gonna do my thing, you're gonna do your thing. So it's a culture change. It has to happen. Transformation has to happen at every single level of the healthcare system. Medical groups have to be willing to redesign and coordinate care differently. Hospitals need to think about coordinating care through, patients being in and then have to coordinate, especially with readmissions, right? That's the next big thing. So if I'm going to be hit with a readmission charge or not get paid for a readmission, I better be talking to my docs out here to say, okay, I'm passing the baton. Here's what happened. Let's make sure that we're having that conversation, right? So that is going to really start different things and different business models. I mean, there are some mega hospitals, and I know that some of you all really don't have that issue, but some of these mega hospitals that when you look at some of the other countries like Denmark, they closed 50% of their hospital systems when they redesigned. Now, that may or may not happen here, but the question's going to be, we've got a whole elderly population coming up in this country. Wouldn't it be fun if we had a different business model and changed the west wing of the hospital to assisted living? Hey, I fall and I can't get up. We'll send the gurney right over, just right across the thing, I love that idea. Is anybody going to take me up on that? I say this, nobody. Don't you think California, they would love that, On the way they see like Disneyland stuff and, I know this is going to work. I'm serious. So health plans, payment reform, they're all thinking differently. They're all redesigning themselves. They're buying practices. They're buying health information exchanges. They're buying technology. They're buying data warehouses. I mean, everybody's looking at this differently. Employers, they're thinking like, I'm a self-insured employer. We now have a huge percentage of the market that is self-insured. They may have a Cigna card, they may have a United card, but guess what? That risk for that patient is actually being covered by a self-insured employer. And there are thousands of them out there, right? So Walmart went ahead and said, you know what? We are just so sick of paying these ridiculously high premiums. GE, $3 billion just on healthcare, right? So Walmart said, you know what? We're going to go ahead and pick 9 centers of excellence across the country. We're going to send all of our like our hips, our knees, patients with hip and knee surgery and high-risk complicated surgeries, we're just going to send them to them. So what do you think of the people in that local area that all of a sudden the primary care is like, well, I'm going to send you to your hospital, and it's like, oh, wait a minute, you can't go to the hospital here, you have to fly out to go somewhere over here to one of these 9 centers of excellence. I mean, that's how desperate some of these things are starting to get. And so this is really becoming, and patients and consumers are completely confused. I mean, how many of you are patients and consumers, right? right? Every one of us. I mean, I've, had my joy of being in the healthcare system, or my family has, right? So we've all experienced this ourselves, and we have to start to think differently as well. What is my responsibility for being a patient, and then what can I expect from the providers that take care of me? So that's all kind of different. So I will say that through all this redesign, you can have the best tactics, the best technology, the best everything, right? This is what's going to make this incredibly difficult, right? Culture Eats Strategy for lunch every single time. We work with hundreds of practices, many hospital systems, many communities, and it would be a lot easier to do this. We have a lot of the pieces in place, but it's how are we looking at this? And you did this to me 5 years ago, so I'm certainly not going to be letting you do that to me now, and blah, blah. So you got a lot of that kind of stuff. So that's going to be some of the bigger challenges, regardless if you're in a big area, big city, or a small town, and it's probably a little worse in the small towns, right? I've lived rural medicine. I've practiced in some of the rural areas. So you have to kind of watch that. And we were just speaking at, in Pagosa Springs, the docs moved out there specifically. They don't want to be told what to do, right? So you have to come at them with a very different mindset of, this is us doing this together. This is not a top-down. This is us saying, how do we, as an integrated community of providers, take care of an integrated community of our folks that live here, right? These are our families, these are our people, these are the folks we see in the grocery store, et cetera. So this whole idea of an ideal state, the shared community vision, and you all can define what is your community. Sometimes it's very well defined by geography, sometimes it's not. So you have to kind of think about that. Shared data is incredibly important. There's so much data that flies now, and that is not available at the point of care still. And I've been on COREO's board. I've been part of the early COHE days. I've been waiting to get point-to-point communication, right? And it's still, I think I'll be 95, but I'm making it there. And they're doing a great job. It's just really complicated, very, very complicated. So, and then of course shared care plans. I mean, wouldn't this be nice if instead of me that has, not me personally, but let's say instead of a patient that has 9 different doctors and 9 different care plans that are all competing with each other and saying different things, that they have one care plan and we all touch that patient through that one care plan. So I know what the endocrinologist, I know what the cardiologist, I know what the surgeon did, right? And the patient's not going, oh my God, who do I talk to? Who's coordinating all of this, right? Okay, so I'm gonna, and ultimately we're really good at fixing things. We are like the best at fixing things, right? We're not so good at preventing it from happening, right? And if you look at our incentive systems, that's exactly what we pay for. Hey, if you do more, I'm gonna pay you more. And employers are saying, guess what? I can't anymore. I can't do this. We had a 28% increase in our company 2 years ago, 13% last year. We're going to have another 8% this year. I'm a small, relatively small company. We can't keep affording to do that, right? And so we have to start thinking, how do we prevent things before they occur instead of fixing them way more down the line, which is much more expensive. So triple aim, here you go. This is for you, Marianne. This is an interesting concept. Many of you have heard this. Now there's all these different iterations, but the basic idea is thinking about individual and population health, which is a little different than what we've ever done, per capita cost, making this affordable care, and the experience of care. Are the patients happy? Are we as caregivers happy, right? Because if we're not happy doing the care, guess what? It's not going to be really exciting for the patient to be cared by us, right? What do you want? Right? Instead of, how can I make your day better? Which, by the way, one of our practices, how can I make your day better? I'm like, whoa. That is amazing. I mean, I walked in an office and they were like, can I get you some coffee or water? What? Is this a doctor's office? This can't be, right? So, this is a customer service thing, right? So again, we are a nonprofit healthcare, kind of a collaborative of many organizations, but really trying to optimize health. And, in our work, what we're really finding is this is going to be the answer here, right? I mean, it is, and if you think you can cross tribal boundaries here, right? We have to think going forward. We have to start thinking differently about, how can we best use each other together to get to this endpoint, to get to these really big goals, because it's going to be hard for each of us to do this alone, and we're going to have a lot of redundancies, and we're not going to have enough resources at the end of the day to do it. So patient-centered medical homes is one of the big models that have come out of this. It goes back to the 60s. I won't go through a lot of the history of it, but it really is what I went into family medicine for. I mean, and I always go, you know, do you remember Marcus Welby? And a lot of the people, like, they look at me like, what? You know, and I'm thinking, God, I am getting so old. You know, I mean, they don't remember Marcus Welby, right? You know, but that was what I wanted to be. I went to Evergreen, Colorado. I was going to be Marcus Welby. We opened the clinic at night and took care of our patients, gave them a breathing treatment, went home and went to bed. You know, that was medicine, you know. But this is bringing that back. It's really starting to think about an approach to providing high quality, safe, continuous, coordinated, comprehensive care with a partnership between patients and the healthcare team, right? And every one of those words in there actually has evidence behind it that says if we do those things, instead of me going to the ER and they don't know who I am, so they're going to run 25 things right on me, I have continuous care. Somebody goes, you know what, I know you've had this before. We're going to sit this out for 24 hours, and if you get worse, you're going to call me, right? That's the relationship aspect where we can really start to do this better. We just had some students, and by the way, one of our practices said, it's the kind of care you want your mom to have. Right, he got admitted like automatically into our pilot that we did, and I'll tell you a little bit about that. So this is taken off across the country. We were one of the 4th pilots, medical home multi-payer pilots to launch in the country here in Colorado, and I'll tell you a little bit about that. But basically, this is, the concepts behind here is kind of going back to our roots of let's put some systems in place so that we can actually free ourselves up to do the things that we should be doing, which is holding the patient's hand, starting to actually do the more complex things that you can't put into a, let's say, if it's an electronic medical record that has kind of a checkbox that says, if you're a diabetic, we need to make sure these things are happening. That's a very easy thing to put onto a tracking list, right? But what's not easy is trying to find out with Lucille over there, so what's really going on? How do we coordinate all these complex things, and how do we make sure you're not going to fall out of bed in the middle of the night and break your hip? So those are kind of the things. So I'll tell you a little bit about the pilot. We had 7 health plans, including Medicaid, one of our high-risk plans, and then 5 of the major plans. And they all got together and they said, yes, we will pay differently. If the primary care docs do care differently, we will pay them differently. And so this is what they had to do. Leadership and team-based care, where they had to really reorganize their care. Patient engagement and access, where they really had to talk to patients differently, motivational interviewing, really bring them with shared decision-making. Care management, care coordination, they were going to be the quarterbacks, right? They were going to hold on to the football to really make sure that they were coordinating these things. If you had high-risk patients, manage them even better so that we could really reach out to those folks who were going in and out of the hospitals and having 4+ chronic diseases to make sure they got that needed care that they needed. Evidence-based medicine, population management, where it's not just one patient at a time. We are still doing acute care medicine. It works great for stitches. It works great for broken arms. It does not work well for chronic disease, preventive, starting to build a relationship, starting to build a story for a patient. So that is really some of the things that they're doing. And of course, technology. You can't do this without a lot of these systems in place and reporting outcomes to say, how am I doing? I mean, how are my diabetics getting everything they need or are they not? Technical assistance, every single one of the practices we work with, we give them an on-site coach to help them reorganize, learn some of these techniques, start to work through them. Learning collaboratives where they come together. We had like 400 people in one of our learning collaboratives. It was the doc, the nurse, and an office manager was the minimum, but they're like, can we bring 7? So, all of a sudden we kept expanding it, but they start to share, it's like, oh, thank God, I'm not doing this all by myself, so that's exciting. And then data. We've never been taught at least in medical school, how do you actually use data, because we've never had it, to drive improvement, right? So it's very exciting stuff, yeah. Yay, right? Was that okay? Yay. Okay, so new payment models. As we're starting to think through this stuff, we're starting to think paying for value, not volume, And how do I, instead of doing the treadmill thing where I'm seeing a patient every 10 minutes and doing triage medicine basically, how do I sit back and say, I've got 2,000 patients in my panel. I've got, these folks just have prevention issues. These folks have maybe one, some high risk or have at least one chronic disease, and these folks are high risk. They're going to be, they got multiple chronic diseases, multiple medications. I need to put some really significant resources for these folks. And then if I put systems in place, all these guys are like, hey, you've had your pap, your mammogram, have a good day, we'll see you next year, right? Those are the kind of systems that can very easily be put into place. Well, I shouldn't say easy. It's like building a house in a swamp with a spoon right now, just because of the environment. But other than that, it's really easy, Redefining visits. I mean, how many of you have electronic communication, like email communication with your docs right now? Or have that as your hospital? Isn't that amazing? It's incredible. I go to Kaiser, I get my physical, I do my thing, get my labs done, I get home, my labs are there. I send a quick email, hey, what's going on with this thing? Oh, don't worry about it, or come on back and repeat it in 3 months. I've just saved 3 phone calls for her, 5 phone calls for me, coming back in to get rechecked, that kind of stuff. That's the kind of stuff that people want and that we need to start doing. So really enhancing access through a variety of different ways to have a contact with a patient. And I can tell you right now, you're going to be sitting in front of your TV one day, you're going to dial to channel 12, and you're going to go, okay, I want to talk to a neurologist. Boom. Okay, so, and they're going to be able to look at your whatever, dermatologist. Hey, can you just take a look at this right here? And they're going to be able to see, I've seen this technology. It's amazing, right? This doc in Boston was showing me a physical exam on herself. I could see better because it was on a screen like that. It was better than me being there in person, right? It was like Memorex. Was that old Memorex commercial? Okay, and then the big concept here is that we're not just telling people what to do. That doesn't work anymore, right? It's like you have teenagers. Anybody have teenagers here? Talk to the hand, right? Stop smoking, you're going to die, right? Okay, stop eating, you're going to die, It doesn't work. So we have to start engaging them, let them set their goals, and we help them get there with our teams of experts to be able to help them with a variety of different issues that they need, and that could be clinical pharmacists, complex care manager, social worker. It could be a variety of different resources, but we're working together to put those together. So it's thinking of the patient not just as what's happening when you're standing in front of me, but I'm thinking of you as a whole person. I'm thinking of you with a customized care plan that I can help you develop, and then I'm going to kind of hand you over to my team to be able to help you get to the goals that you need. Very different thought process here, right, than what we've been doing in the past. And again, this is what we call, it's empaneling and risk stratifying your patient population so you can direct the care where you really need it the most and make sure that everybody gets what they need. So medical home without an integrated medical neighborhood, the island thing. And I can tell you, as a primary care doc, sometimes it would be Friday afternoon, 5 o'clock, somebody walk in with suicidal ideation, right? Who can get a hold of a psychiatrist at 5:01 on Friday, right? So, ER visit, it was an automatic, right? So again, in smaller areas, when you've got small rural hospitals, these things are going to make some big differences, especially, you were saying 20% of the patient populations are uninsured. That's going to be a very tough thing for you to carry when you're trying to survive, right? So these are going to be some things that, how are we going to use our neighbors more effectively to make sure that we can really deliver care where it should be. And that's where you start to think about integrated communities of care. How many of you have heard of the ACOs, Accountable Care Organizations, right? Accountable care organization is really, it's more of a business model. It's, all right, you can imagine, how are you going to get all these docs to play together, share a bucket of money, take risk? It's like a bloodbath, right? I mean, we are like, I'm more valuable than you. Are you kidding? I'm more valuable than you. It's like, I don't want to be at Kaiser's table when they're doing this, or Denver Health, or some of the other ones, but they get through it. And by the way, they all are working together toward the same goal. Right? So ultimately, we're going to be looking at medical homes, primary care kind of being the base and the foundation. We can do a lot of that work, but ultimately then working with the whole rest of the neighborhood to make sure we do this as effectively and efficiently as possible, all on the same incentive plan. If we do better together, we all get paid better, right? that's kind of the concept of starting to put these systems in place. So I won't go through this in detail because I know we are kind of late into the evening, but I will say that in our pilot, in trying to just build that medical neighborhood, this is no easy stuff, right? I mean, trying to get mental health, behavioral health and physical health to talk to each other. I mean, truthfully, you see the dogs, I shouldn't say this, but the dogs at the park, they're kind of sniffing each other. I mean, I hate to say that, but it was like, they were supposed to meet for lunch, and of course the psychiatrists, they were sitting there, the mental health folks were sitting there waiting for the MDs, and they just kind of wandered in, like, see, they don't care about us. They think we don't count, right? So after they kind of went through all of that stuff, it was amazing to see where they started, and after starting to get them to talk to each other, starting to get them to see the same vision, and that each one of them needs each other, almost by the end we had almost every one of them not only screening for depression, but they either had somebody co-located in their office at least a few days a week, or starting to integrate into their office, or at least having a very close bridge. Okay, so if that's going to be a huge issue going forward. When you look at the dollars we spend in healthcare, having one mental illness or like a depression or some other mental illnesses plus one chronic disease is about equal to 4 chronic diseases, right? That's where the complication rates start. So we have to start to think about how do we put the head and the body back together, right? We somehow separated that out. And I can tell you in family medicine, I must have seen 40 to 50% of what I saw were people that had some kind of behavioral health issues that really needed to be seen as a whole person. So these are the kind of things that if we start to share resources, and if you say, you know what, for a community, a small hospital area in a critical access area, if we say, all right, you've got, we can actually all pitch in and share a clinical pharmacist. I don't need one at my office 24/7 for any, by any means, and they're not cheap, but what I can do, or I can talk to the Walmart next door and say, well, you guys work with us as our clinical pharmacist. And we've done all of these different, testing to see how that would go. You can actually start really sharing resources and get a really good return. Everybody gets what they need, and you get such a better product for the people that we care for. So I am not going to lie to you, transformation is a bit hard. Sometimes you're gonna wind up on a different bed. So a little change fatigue, if you guys heard of change fatigue, so that poor little dog. But it is hard, it's lifting heavy stones, right? But why do we do it? We have seen some incredible results, not just in our studies, but across the country that are coming out with study after study, results after results that are saying, you know what, we can do this. It is possible, and we're seeing some good outcomes from that. This is just kind of the idea that says you can't build a house without a foundation, so you've got to start talking to people about building teams within, their own offices, building teams, information systems, self-management support guidelines. These are all kind of the baseline principles. You can see in our pilot, every single one of these things went up from where they started at baseline to within the 3 years. They really started to build a lot of different systems and talk to each other different. Then they start to look at the quality measures. How are they going to improve diabetes, cardiovascular, preventive things? Then you start to look at the cost aspects. How do we reduce costs, usually through reducing unnecessary ER visits, unnecessary hospitalizations? Now, I'm a CEO, CFO of a hospital, and you're going to do what? You're going to decrease my ER visits and my hospital admissions, which is my bread and butter. How am I going to think about this going forward? And that's where we get back to the we. We are seeing that consolidation, and what hospitals are saying is, you know what, if we become a system, not just a hospital, then it doesn't matter if we're filling beds. We can start to reduce some of our costs in there, and it's the big overhead issue, and that's why I was saying take your West Wing, turn it into something else, then your overhead starts to go down and you start to offset the overhead. Now you've got your patient population seeing mostly outpatient unless they absolutely need it. And when they need it, they need it. Let's get them in for crushing chest pain, right? So it's starting to, again, put resources, and the big thing, and I'll talk about the payment models that are coming, why you care, because this is how it's going to start to happen. We're already seeing Medicare doing this. That whole ACO model is that global capitation. You're, the ones that are going to compete will take a big bucket of money and say, we'll take the risk on this, and we'll be, if we manage it well, then we're gonna do well. You know, if we don't manage it well, we may even have to pay some back. Okay, that's, you know, going to be the longer term aspect, but there's a lot of steps before that. Patient sat on this stuff, amazing. I mean, even through all this chaos, the sats stayed pretty high for patients, but what really I loved is that the patients started to get it. They were, you know, they started off with, yeah, I like my doc, I can't ever get in, da-da-da-da, to I now have all of the skills that I need to manage my own health, 100%. You know, it has improved 100%. That's the kind of stuff that we want to start seeing. So I will talk to you about the data on this. We actually showed a return on investment. This is the only thing that's been published so far, although I have had conversations with the other plans. We've seen anywhere from a 2.5 to a 4.5 return on investment. For every dollar they put in up front, they were getting a 2.5 to 4.5 back. I would like to get that on my bank account, you know, at this point, right? So this stuff can work if we put it into place, which will benefit kind of everybody. And this is kind of showing the gaps with and without medical homes for that coordination aspects. You know, we do much better across the whole world when we start to use, you know, areas where patients can come in and be able to go in and out, and somebody's coordinating some of that. So I'm going to very quickly talk about the Comprehensive Primary Care Initiative, and let's see here. It's already 9:15. My gosh, I knew I should have talked through dinner. Is everybody okay? I know it's like, get the fan out. Let's, you know, I can get the fan going. Just pass it around the table. So Comprehensive Primary Care Initiative is now Medicare's jumped in. And they've jumped in now for the last few years. They have the Innovation Center. How many of you guys have heard of their Innovation Center? They're dumping billions of dollars into this, right? Some of it is going to really starting to, how are we going to test different models before we just comprehensively change everything so that we can see what's working and what's not working, right? Because it's going to take a long time to work out some of these bugs. So this is one of the models that they're using, and we got selected partially because of the pilot that we did with all the payers. So they said, look, we're going to look for regions all over the country. Medicare, who's the big gorilla out there, saying we can't even do it alone. We need all the other payers to join us, because if we do it and we're only 20% of a practice's coverage, and they're doing a comprehensive change, what happens to the other 80%? They got to fund that themselves. They don't have the bandwidth to do that. So if we increase the penetration across as many plans as possible and as many employers as possible, then when you've got this all in, then we can start to really see some differences, right? So Colorado's doing this now. We launched a year ago, November. And it's in 7 regions across the country. This is going to be a 4-year initiative, and they are paying the practices differently. Fee-for-service, their normal treadmill thing, plus a care management fee, which is the same as our pilot, plus shared savings. So the idea, we had a pay-for-performance bonus, but their shared savings is, look, if you guys do well and we see some savings out of this, you will get a share 50% back on that. Now that's some potentially some dollars for them to be able to reinvest, as well as maybe take a vacation, you know, would be kind of nice. So Medicare's paying anywhere from $20, that's their average, to, you know, if it's a very complex patient, they're doing risk stratification of the patients, and they say, we'll pay you up to $100, maybe $120 for that patient per MPM per member per month. Right? Because we know it's going to take a lot more. What happened in the managed care days? This is another lesson learned. Everybody's like, wait a minute, I'm at risk for these patients. I'm going to start dumping patients. I'm going to cherry pick. I want the healthy ones, right? That's crazy. That's the ones that we need to take care of the sick people so we can keep them healthier, you know. So that's really one of the learnings, and you can see that that's been adopted. And these practices are redesigning. We have 74 practices. We're doing 60 of them, and Rocky Mountain is doing the other 14. So I want to talk a little bit about these payment models, because whether you're in a critical care hospital or in the industry serving a lot of these folks, These things are starting to happen. They're being tested all over. And what we're seeing is there's definitely kind of this decreasing aspect of fee-for-service with an increasing aspect of fee-for-quality, right? We're going to pay for quality. We're going to pay for value, not volume. The problem, the difficulty is the transition. So remember I was talking about, well, what are we going to start thinking about if, and this is, you can see this out there, right? And I've got to stop and get my camera out, where the hospital's saying, hey, wait times at the ER, 5 minutes. You can get an app now, right? And see what your wait times are. While the primary care docs are killing themselves trying to say, we're keeping people out of the ER, don't do that, you know? So we're obviously in this transition where everybody's trying to say, well, I've got to live. I'm not going to cut my right arm off. I've got to start to figure out how to do this, even though I'm building toward the future. Well, that's going to be the question, is what are we going to do to get people from here to there, right? And that's going to be, I think we're starting to see some people are getting over that hump a little bit and starting to feel like, all right, payers are starting to come forward. They're starting to pay me a little differently. That will help me build some of this infrastructure, and it's going to kind of walk its way through that way. So just some things to consider if you're bargaining for a contract. Again, you want to be negotiating with all your payers, but if all your payers, and if you've got now rural, I know usually Medicare, Medicaid, is that the same in California and Oregon? Do you have a lot of private pay? Okay, so you guys aren't as much in the issue. Colorado is an interesting thing. We have no dominant payer. We had, you know, in the East and some of the other places, they have Blues, 80% of the market, right? Well, that's easy. If they're going to play, great, you're in good shape. If they're not, nothing you can really do, right? Medicare is now starting to talk about this. Medicaid here in Colorado has a RICO, which is that's their model for this payment redesign. How's your Medicaids? Are they coming in at all? Okay. So you're perfect. And California?
Not sure.
Not sure. Idaho? Wyoming? Idaho, Wyoming.
You're not playing.
You're not playing. Okay. All right. So you guys are going to be so far ahead of everybody else. I mean, really, you're going to go back. You're going to be, you know, bargaining all these things. But the idea is you want some money up front to be able to build a solid infrastructure, and that sometimes is difficult to negotiate, but it's worth it. Then you kind of maintain that infrastructure over time. Then you start to get some of the other dollars later, but that can be 2-3 years later. If I'm putting EMRs and I'm putting all these systems in place and I'm putting care managers and I'm doing all this stuff, I better make darn sure that I'm going to get something back or else I'm going to go out of business. So those are kind of the risks that you're going to have to start bargaining and thinking about. Incentives to bring everybody together, and then incentives for patients. Wouldn't that be cool if patients were incented to the same things that providers were? So instead of us saying, oh, she's so non-compliant, we don't ever say that. Do we ever say that? Actually, we charge our docs $1 if they say that. They have to put it in a jar. We have a big party at the end of the year. But if they're incented to the same things, we're all now rowing in the same direction. That's a really good thing. So blended models, why? You know, we've seen everything under the sun. Salary, you get problems with productivity, fee for service, problems with overuse, capitation, underuse, pay for performance. I'm just going to do that. So how do you start to think about this as blended models? And you take pieces of this. So right now, most people are on a fee for service, right? This is the treadmill. Not many have the care management fee for that, you know, that what's not in a fee for service to do and build your infrastructure, or a pay for performance, and not much shared across the neighborhood. As you start to evolve, that was our pilot, and that's also CPC, where you start to get a little bit closer off the treadmill. Here's what, does anybody know what this is right here? I hate to say it out loud. Capitation. This is capitation, right? Now don't tell any of my docs, okay, because we have been really good at not saying that word, because everybody gets nervous about it. But when you look about it, how am I going to get off the treadmill? Give me a salary, give me something, but don't just say that's it. Tie it to quality later, because if I'm just looking at cost, I'm going to do everything I can to play the game, right? I need to show that I'm actually getting outcomes. I'm doing something for that, right, for that salary. And that didn't happen in the managed care days, right? The last thing then is, and I want to make sure that my hospitals and my specialists are playing with me, or I'm going to be throwing the football and they're going to be like, you know, it's bouncing off. We all have to be starting to get incented to the same direction. And this is where I was talking about global cap, right? So this is everybody's in the bucket. where they're all sharing, everybody's got the same incentives, working together to get to the win, and really redesigning to make sure that everybody is going to be, we're going to get people to the right place at the right time. And then meeting people where they're at. So I will just say I had a little bit of a very tense moment when I was sitting in a lecture. We were 2 years through the pilot. We were 1.5 years through the pilot, almost ending. And I see this graph for Vermont, one of my buddies in Vermont, and they didn't even start to bend the cost curve till year 3. I'm like, oh my God. So I ran home and we started to do a whole research thing, and we talked the plans into an extra year, right? Well, so when they started these pilots, it was taking 2 to 3 years to start to see any reduction in cost. What we're seeing now, we had a pilot in Fresno. Within 6 months, the school district, oh, you can't see that yet? Don't laugh. I blew my whole time. Anyway, Fresno, right? So we go in there, the school district, they're going broke, right? It was like, we can't afford this anymore. They went direct to the docs, they said, help us, right? Help us. They talked, and they were working with this hospital system very closely as well. And so the question was, we helped them put the systems, we helped them coordinate with the hospital. Within 6 months, they were saving already a few $1 million. They had managed to change many of their quality measures. By a year, they had saved many more millions, right? This can happen, and it's starting to happen all over. So, all right, here you go. Right, can this happen? Are you guys skeptical? No, this is like, yeah, it can happen, but it's tough. And that's why you all especially, it's kind of the runners to your mark, instant gratification. Well, I hate to tell you, but it's not going to be that quick. So, we do have to, anything in life, you look at the airline industry, you look at the banking industry, when they started to comprehensively transform, and I think the airline industry needs some help right now, you have to really put investments in to get to the other side of the kind of that chaos curve. And I end every single one of my talks because at the end of the day, regardless of what systems or technology or processes or any other tactics you put into place, it really is about how we work together in teams, how we work with our neighbors to build accountability to each other in the communities, and of course with our patients. So, so let me just, how much do I have? A few minutes for questions?
Yeah.
Okay, all right.
Yeah, that'd be great. And then,
Perfect.
And thank you, Margie. And then we're going to go up to the lounge and people and mingle and.
Okay, now you're putting me between alcohol and these guys? Okay. Yeah, there we go. No problem. Okay. So what do you guys think about this? I mean, tomorrow you're going to have some really deeper conversations about how is this going to affect me? Am I thinking about it? Am I not thinking about it? Do I care? Is this something in a rural critical access hospital that's going to really matter or not? Will I be able to survive as a single hospital system? We were kind of talking about that. I think you have a much better shot than if you're a single hospital system in the middle of a city. But I'm seeing mega systems. I mean, they're not even just in the 90s. It was like, yeah, we'll kind of see some consolidation. We'll buy some practices. Now it's like you're seeing that fish thing eat the other big fish, and you've got like, I'm trying to think of what was the biggest hospital. It's like this mega system bought this other mega system, and now they're like, I mean, they've got like hundreds and hundreds of hospital systems across the country, right? Because they want to be able to have enough bandwidth to take that risk, right? So what do you think about this?
Me?
Yeah, I thought I just pick on you a little bit. Yeah.
I guess I'm still trying to figure out the difference between an ACO and the patient-centered medical
Home?
home.
Okay.
Because it seems to me it's the same approach, same definition, and you're congregating with a set of funds, right, that's distributed to the group, and based on the success or failure of the group,
Yes.
they make more money or not.
So far at least, you've kind of had this movement where primary care came together, and it was mostly, interestingly enough, the internal medicine and family docs, right? And the peds were there and the osteopaths were there, but they didn't, and the peds were the ones that started this in the 60s, but they don't have as much to save, right? They take care of mostly healthy folks. So a lot of the pilots involved family medicine and the internal medicine. So there was the medical home was really building primary care which doesn't just have to be family docs and internal medicine. It really is any kind of point of access that's primary care, building that as the foundation. Then they start talking about ACOs. It's like, well, you can't do that without a neighborhood. So if you start to talk about how are we going to take risk at some point, you can't do it single practices, right? You just don't have enough bandwidth. So that's when they started to, this model of, Mark McClellan and some folks came out with this model for the ACOs, which is then saying, all right, well, if I'm a hospital system, where am I going to fit in this? And I'm specialist, then how am I going to survive? Well, you're going to start to potentially bring your primary cares in, because if you start to see the headlines now, primary cares are back in vogue, right? For a while, we were like the janitors, and maybe you could get a job, right? And so now it's like they're really trying to get primary care docs back. So now you're going to have to say, well, that's great, but we want to play too. And it was that whole aspect of, in the 90s, we didn't play as teams together, so we couldn't really we failed because we couldn't get that whole picture, of the whole community playing together. So the medical home is that primary care foundation. The ACO is that business model that is able to connect hospitals, primary care specialists, and whoever else you want to put in that circle. Yep. Yep. So it's going to be really interesting, and I think, I think we were talking, Monica, about where are these critical hospitals? Will Medicare continue to, basically fund, that at the higher rate? I think you still have a very good case. Who else? Thank God, again, you guys are out there. Nobody else is out there delivering this care. So you have an advantage from that perspective. Then the question is, how do you start to use technology better? Because you're right. Why would I want to have my patient drive all the way back to the university hospital when I'm, 8 hours away from there, if I can do this very easily with that, like I said, they used a Polycom over a very secure network that is a, 20T or whatever you call those, really high-speed connection. So it's not like Skype where you kind of look like a frog, by the time, my brother and his family live in Israel, so we're always Skyping, and I always look, kind of like, do you really look like that still, anyway. So, it's getting so much more sophisticated. And so if we start thinking, you guys have an opportunity, I think, to think really innovatively, right? Because of the advantage or disadvantage that you have an opportunity to say, okay, how can I use some of the technology that's out there to connect up with some of these specialists? Like in one of our small towns, they didn't have a radiologist. I used to lecture on delays in diagnosis of breast cancer. Well, that may not be a problem if you don't have a radiologist. You're not even going to know, which is a bummer because these poor patients didn't have any way to get that test. So you can drive out a mobile place for that, which is fine, but who's going to read it? So that's where they start just using technology, right? And they can get their films read, almost instantaneously. So there's a lot of, and that's what I love about this time period, because it's going to be the innovations, the disruptive innovations, because, and I work in this every day where it is, like I said, it is painful work, it is hard lift, it is very very time consuming, very tiring. At some point we're just gonna see the folks jumping over that and say, the heck with this, we're gonna just do it this way, and boom. And I think it's gonna be the technology, it's gonna be the genetic, some of the genetic stuff that's coming, it's gonna be some really exciting stuff. So you all have some opportunities, I think, but you got to work with your payers, right? Because if I can't get my specialists to get online because they're not getting paid for this, how am I going to incent them to talk to my docs, So that, again, is going to be some really interesting things that are coming down the line. Anybody else? Like, what are some of I know you're going to talk about this a little bit more tomorrow, but you had some, interesting things about my docs are there because they want to be in Bennett, So here goes the transition, right? So I've got all these incentives now that are completely opposite for where the world is going, and I'm going to have to figure out how to step over these incentives or over these barriers to get to where I know we need to be. And that's going to be a really good question, you know. Now, if I've got a lot of people moving into the area and I can actually, you know, so that may be where you start to look at your population stats and start to see, you know, how many patients are we seeing every year? Is that number going up or down? And by the way, with the exchanges coming, and I think, and we tried to do this study where we were working with some folks in the state to look at where are these people coming from? You know, I mean, we know they're going to mostly be along the Front Range because that's where the majority of the population is, but they're going to definitely be coming out of some of these rural areas, right? I would imagine. So I'm going to think that from an access point of view, you're still going to, at least in the interim, be able to meet some of your productivity targets. But I think that's worth looking at. You know, how, you know, can you guys start to get those numbers of who's going to be in the exchange and what % of the population that I'm serving? Yeah. So that, I think that's going to be really important for you guys to start looking at those to say, okay, first of all, what's going to be the demand? Because I better be ready for it. And maybe that'll also be the secret sauce to keeping up those while you're trying to redesign. Are we ready to drink?
I think we are. Thanks, Margie.
Yes, absolutely. Yeah, thank you.